Good morning and welcome to the American College of Lifestyle Medicine's complimentary webinar on payment advancements and Medicare Physician Fee Schedule updates. What lifestyle medicine clinicians need to know. Thank you for joining us. Next slide, please. Before we dive into today's presentation, I want to share a bit about the American College of Lifestyle Medicine. In the US, chronic diseases are the leading cause of illness, disability, and death. 3 in 4 adults have at least one chronic condition, and 90% of national health spending goes to chronic physical and mental health conditions. Yet, most chronic disease risk is driven by modifiable lifestyle factors. Next slide, please. ACLM is a national nonprofit medical professional association dedicated to changing the trajectory of non-communicable chronic disease in the US. We represent a galvanized force for change. We advance evidence-based lifestyle medicine to treat, reverse, and prevent chronic disease. Next slide, please. What is lifestyle medicine? Lifestyle medicine is a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic conditions. And lifestyle medicine certified clinicians are trained to apply evidence-based whole person prescriptive lifestyle change to treat and when used intensively, often reverse these conditions. Applying the 6 pillars of lifestyle medicine: optimal nutrition, physical activity, restorative sleep, stress management, avoidance of risky substances, and positive social connections also provides effective prevention for these conditions. Next slide, please. Through education, training, certification, membership, partnerships, practice support, and advocacy, ACLM equip and unite clinicians to deliver health restoration and accelerate a future where lifestyle medicine is the foundation of health and all healthcare. Next slide, please. We invite you to join us as a member in our mission to restore health. Next slide, please. And now it is my great pleasure to introduce our speakers today, Dr. Jake Quinton and Gervean Williams. Dr. Quinton serves as Chief Medical Officer, Parts A-B at the Center for Medicare. As part of the leadership team in the Center of Medicare front office, he works to improve the value and quality of care for Medicare beneficiaries, focused on original Medicare. Dr. Quinton is a primary care internist with a focus on improving value, access, and equity in U.S. healthcare. He completed his medical training at LSU New Orleans School of Medicine, where as an Albert Schweitzer Fellow, he led programs to improve reproductive health education in New Orleans public schools. And with an interest in health disparities, founded and led the first student hotspotting program in New Orleans. He trained at Yale New Haven Hospital in their internal medicine primary care program with his outpatient clinic at the West Haven VA Center of Excellence. His research during residency compared risk indexes for hospitalization and mortality at use in the VA, which won the Hopkins GIM House Staff Research Award in Population Health. Gervean Williams is the Director of Health Center Financial Training in the Training and Technical Assistant Division of National Association of Community Health Centers. Ms. Williams has 20 years of healthcare experience. Before joining NAC, Ms. Williams was the Vice President of Consulting for PMG and was the Chief Financial Officer at Samuel Rogers Health Center. Ms. Williams is a former Rogers board member, co-chair of the Mid-American Regional Council HIT Committee, and served as a member of the Diversity Council for the St. Luke's Health System. With that introduction, I'm delighted to turn the program over to Jake, who will guide us through his presentation. Jake, take it over.
Thank you so much, Dr. Patel, and thank you to the American College of Lifestyle Medicine for having me today. I will be speaking without slides, at least for the time being, and so grateful for your attention, and I'll do my best to signpost this presentation and I'm certainly looking forward to Gervean's slides here in just a moment. So first, I wanted to say thank you as a practicing primary care clinician and as a lifestyle medicine fan, although not ACLM trained. I am delighted to be the first chief medical officer for Medicare Parts A and B. And I wanted to quote for you what we said in the physician fee schedule last fall. That CMS is reinforcing primary care, and I'll add to that lifestyle medicine, as the foundation of a better healthcare system while ensuring Medicare dollars support real value for patients and not the kind of waste or abuse that erodes trust in the system. Our goal is simple: deliver better outcomes for patients and be wise stewards of the taxpayer resources that make Medicare possible. I realize I'm speaking to the lifestyle medicine community today. It's been great to learn more about lifestyle medicine as we look for evidence-based approaches to support the Secretary's Make America Healthy Again priorities. I'm sure you've seen quite a bit about the initiative, and you also likely saw, at least for non-FQHCs, we updated a prior G code. It's G0136, and there'll be a few G codes we'll talk about today to focus on core clinical medicine topics, in this case, diet and exercise. What could be more central to lifestyle medicine? You've seen a lot more about MAHA from the Secretary's office that I think is broadly aligned to the pillars of lifestyle medicine, even maybe that Super Bowl ad. But I want to focus more directly on the technical aspects of the physician fee schedule. I'm going to break this presentation into 3 parts. I'll describe where CMS is going more broadly as we move the $1.2 trillion in payment between the original Medicare and Medicare Advantage programs and our strategy at the Center for Medicare. Next, I'll talk about what we did specifically in the fee schedule last year. And finally, to the extent that I'm able, given that we are in the process of developing proposals for next year's rulemaking, I'll share a few high-level notes about our plans for the future. So first, if I could summarize where the Center for Medicare is going in one sentence, I would say that we are looking to make competitive the original Medicare program compared to Medicare Advantage. And when we think about rebalancing between Medicare Advantage and original Medicare, we think that's going to take a few key steps on the original Medicare side of the house. We think the fee-for-service system is certainly a cornerstone, but outdated, and we need to evolve beyond the current fee-for-service architecture. What that means for the lifestyle medicine clinicians in the room is that we're expanding our ACO program and looking to grow the participation and the savings rates for both the Medicare Shared Savings Program, the largest ACO program in the country, and the existing CMI ACO models and ACO Reach and future ACO Lead. We also think that in addition to evolving and doing lots of fun technical work in the fee schedules to incorporate additional data to support decision-making and setting our payment rates, to trying to look to other markets for data to help us set rates, and expanding the ACO program, we really need to think critically about our Medicare operations. It's remarkable how efficiently the Center for Medicare is able to administrate and adjudicate claims for the clinicians caring for Medicare patients. But we also acknowledge that the technical infrastructure for that claim set is outdated, and we need to make important modernization requirements. We have a series of plans over the next 5 years to modernize the claims architecture. But really what this means is, how can we do our job more efficiently and continue to be the best payer? Now, that's the original Medicare side of the house, and I'll speak just a few words about the Medicare Advantage side, just to say at a high level where we're going, and you saw much of this in the advance notice just a couple weeks ago. First, we're continuing to overhaul the star ratings, trying to move more towards outcomes-based measures, streamline the measure sets, incorporate where we can more important measures of prevention aligned to lifestyle medicine tenets. We're continuing to reform risk adjustment, and you saw that the big feature of the most recent advance notice. We're cracking down on contract gaming. We think gaming and other areas of borderline fraud, waste, and abuses, we need to be not just important stewards, but we need to be really aggressive in cracking down contract gaming wherever it raises its head. And the last two pieces are probably closer to the vest for everyone care for Medicare patients on a daily basis, but we're working more aggressively to lower drug costs. You saw the Trump RX work and the really important pilots that have been established, principally led to the Center for Medicare and my boss, Chris Klump. And then last but not least, we need to reform the burden of prior authorization. We understand this is a remarkable sticking point for all of us, the care for patients. And while it is important to have appropriate safeguards for utilization, we need to make this process streamlined for the docs in the room. So that's where we're going at the highest level for the entire center, that entire $1.2 trillion program. In terms of the fee schedule, we acknowledge that federal rate setting is very difficult. Historically, the best sources of data to evaluate physician services has been the surveys we've given physicians that have been compiled by typically the AMA-RUC and established to help us understand sort of the resources and costs associated with caring for patients. We think we can improve this in two big areas. One, you saw an example in the remote therapeutic monitoring, remote physiologic monitoring codes that we were able to use data from different payment schedules to help us set prices, to really get at what is the actual empiric underlying utilization and underlying time and intensity of service that is going to be important for helping us understand how to set prices most fairly. And second, in addition to empiric data, we're looking to in addition to empiric data, we're looking to see where else in the market we can learn from. What are commercial payers doing? What's happening in different areas of service delivery? Where can we use them? Where can we leverage the power of the markets to help us set federal prices? So what did this all mean for the fee schedule last year? Overall, in the physician fee schedule for primary care physicians and for lifestyle medicine docs, I hope you saw that not just in rhetoric, but in action, there was about an 8% overall increase in payments to primary care, as reported by the American Association of Family Practice. That was a result of a number of policies, including the 2.5% APM bump as part of O3BA, but also to a series of structural reforms that I want to walk through. And I promise this is exciting, innovative, and really important foundational work. These structural changes are underneath all the specific coding changes we'll talk through and Gervean will talk to in just a moment, but I want to talk about two. The first is, for the very first time, the physician fee schedule has incorporated a productivity adjustment. We call it the efficiency adjustment. And we're going to talk about what that means. And then if you think about if we walk through kind of like what all the steps to create a bill, the CMS version of that is all the steps to create a code. There's the work that's associated with the physician service. There's the practice expense, the stuff that goes into caring for the patient, the supplies, the overhead in the building, that sort of thing. And then there's some geographic risk factors and professional liability. But all those pieces sum together or how we set payment rates. And one element of that we really needed to update. It's the indirect practice expense. We haven't really made changes there since my parents' generation were physicians. And we want to recognize there's been important changes in clinical practice since then. I'll say two words about efficiency adjustment, the practice expense piece, and then we'll talk about the exciting code changes. So on the productivity factor, we recognize that that fundamentally, when we are setting physician prices, typically that's happening when services are new. Oftentimes, these are survey evaluations that are presented. Say it's a new version of a hip replacement, new version of a bone marrow transplant, what have you. And for these procedural services, naturally, there's the ability, naturally we get better at them over time as physicians, and so we can move a little quicker while still delivering the highest quality care. That is not the case for the important counseling and lifestyle change and elements of primary care practice and lifestyle medicine that are valued typically in your evaluation and management and non-time-based services, or sorry, inherently time-based services. What's critical here is that we think that there has been a passive devaluation, and this is how MedPAC puts it, of the inherently time-based services because we're not taking histories and physicals faster. However, we can get faster at the procedures we do. So we incorporated this productivity factor this year, and it went live as of January 1st. And we think this is an important rebalancing and acknowledgement of primary care and lifestyle medicine at the center of the health system, and our ability to support patients in making these really important lifestyle changes that are going to help make America healthy again happens principally in that clinical setting, or is founded in that clinical setting. One more note on the other structural piece that we worked on. In that practice expense component, there's the work units, there's practice expense, and there's professional liability. In that practice expense component, we actually initially had priced it at the Center for Medicare as we thought that, at the time, clinicians typically had an inpatient setting where you'd round, and then you go see patients in the clinic. And that's why my parents did it. However, now we recognize we typically practice in one of two places, either principally inpatient, the hospitalist in the room, or the outpatient docs that I think I'm speaking to principally in lifestyle medicine. So we needed to make some updates. And so we updated the indirect practice expense to account for that change in clinical practice. But what I think you're most excited to hear about, and thank you for being patient with me as we walk through what I think are some of the most fascinating elements that undergird the entire fee schedule. Let's talk about three specific things and changes that CMS made this year in the fee schedule before I hand it over to Gervean. First and foremost, I want to talk about advanced primary care management. This is a new service as of 2024 for and it's just, we made some small changes in 2025, and we are incorporating population-based payment to streamline care coordination and streamline case management services that have existed for the last 15 years through chronic care management, principal care management, transitional care management. All of these services, we want to lay a foundation and say the basics are here in advanced primary care management. It's no longer going to require time-based accounting. It's straightforward to bill. And we think that this is going to be an important element for future prospective population-based payments. So there are 3 levels to the code. If depending on the number of chronic conditions or whether a beneficiary is a qualified Medicare beneficiary. However, we think this is a first step in the fee schedule to account for that really important between visit care and coordination. And we think that it's been accounted for in a way that has made it difficult for clinicians to bill, and we're streamlining that for you all. So that's advanced primary care management, and watch this space. We expect to do more there in the future. Second is telehealth. We just want to say that, and there's some good materials from ACLM on this. We essentially said the important experiment, and one of the few bright spots to a very dark cloud that was the COVID-19 pandemic was our rapid understanding of how you can safely deliver telemedicine services at a national basis. And we were forced to do it. We were forced to learn and transition. And we learned very quickly that which services could be included and which couldn't be. And we'd extended those for many years after the pandemic. We functionally just made many of those services permanent. I want to call out one. This is an important code for lifestyle medicine. It's G0473, and this is a team-based visit focused on obesity. We want you to be aware of that. It just says remains on the telehealth list. I promise I won't walk through too many G codes. And then last, in terms of specific services, this is not one where we've made changes, but I just wanted to highlight that everything we've learned in our new strategy to support the Make America Healthy Again priority is that lifestyle medicine really can be delivered on a one-on-one basis with me speaking with my patient. However, it really appears that we are currently allowing our lifestyle medicine clinicians to exist in a gray area of shared medical appointments. These care delivery models that help transform patients' lives oftentimes benefit from having patients in a group setting. And while there's no specific change last year, I do want to just highlight that the current guidance that we understand many sophisticated lifestyle medicine programs are implementing to incorporate shared medical appointments is valid. And so that while there may be future work to clear up that gray area, we think right now, as clinicians are delivering group visits with these small groups of patients and having shared didactics on important elements of lifestyle change, and then individual tailored care plans, we just want to reemphasize that that's current valid billing practice, and want to make sure that the lifestyle medicine community knows and that we acknowledge this is a gray area. There may be more work to do to at least clarify this for you all and provide additional guidance. But what you're doing right now is really helping patients live healthier lives. So just to wrap up, CMS believes that primary care and lifestyle medicine are the foundation of a healthcare system. We made structural reforms to the fee schedule with the introduction of an efficiency adjustment. We did some under the hood work in practice expense that we think reflects how we take care of patients today. And broadly speaking, we are looking to modernize payment accuracy and support lifestyle medicine as you're the experts in lifestyle change aligned to the MAHA priorities. Just a couple of notes in terms of where we're going. We deeply believe that high quality care is accountable care. And I'm here today to say that the future of lifestyle medicine, the future of original Medicare, and it goes through the shared savings program and our ACOs. We're looking critically now about how we can modernize the shared savings program, make it work better for primary care in general and lifestyle medicine more directly. But I want to speak plainly to my fellow primary care docs who are taking care of patients and helping them make lifestyle changes. If you're listening to this call and you see Medicare patients in the original Medicare program, this is non-Medicare Advantage, you should be part of an ACO. And if you aren't sure you're a part of one, you're not alone. If your patients aren't sure if they're aligned to one, they're not alone. But please check and let your administrators know that where we're headed at the Center for Medicare is expanding in our ACO program, and we want you to be part of that. Along the way, we're making improvements. The CMI's got a new model ACO lead that's going to be coming out soon. But while CMS is dedicated to making primary care better and helping to support lifestyle medicine, the future original Medicare, including primary care, is through ACOs. And that's going to be a large part of how we're balancing the table between traditional Medicare and Medicare Advantage. Unmanaged Medicare is on its way out. And so if you take care of patients as part of your lifestyle medicine program, we encourage you to join either the future lead model as it comes out or one of our current shared savings offerings. So thank you very much. Really happy to speak, yes, about some of the arcane details of the fee schedule. However, this is essential for our clinical practice. We made some important changes aligned to the Secretary's priorities this round. There's more to come, and I'm very much so looking forward to learning from ACLM and their important priorities, continuing to be in dialogue with Dr. Patel and her team, and continuing to help support these really important evidence-based approaches to making America healthy again. Thank you.
Thank you so much, Jake. That sharing your insights, that's so valuable. And we'll come back to answering some of the questions that are already coming up. But we'll move on to Gervean. Please take it over.
Thank you so much. Just one aside before I get started. I love the fact that CMS is looking at lifestyle medicine this way, because we all know that when you see a provider in the room, that 20 or 30-minute visit can only have a 20 or 30% impact on the actual outcomes of the patient's health. So looking outside of that visit in the office and what they're doing for food as medicine or upstream drivers of health and all those things, to look at the whole person. I'm really excited about how the country is moving to really consider all these different things that impact patients. My little squirrel there. But thank you so much. Thank you so much for the opportunity to present to you today. Next slide. So I work for the National Association of Community Health Centers, and we are FQH, federally qualified health center specific. But a lot of things that impact us impacts the rural health clinics across the country. We both serve the same population, underserved people in different communities, but we are reimbursed differently so far as our actual visit. The rural health clinics are reimbursed by an all-inclusive rate, and the FQHCs are reimbursed by a Medicare PPS rate. But these things I'm going to talk about with the Medicare fee-for-service impacts us the same way. So that's why I put both of those on this slide for here today. Next slide. So looking at the FQHC area, every year, CMS reevaluates our base rate for our Medicare PPS rate by the FQHC market basket rate. And these are the rates for 2026. CMS uses a lot of different data in order to calculate what the FQHC market basket rate is, but we have two different things that CMS use. They use the Medicare Economic Index Factor, the MEI, and then they use the FQHC market basket rate. So until the last 2 years, the FQHC market basket rate has always been higher than the MEI for CMS. And this is Gervean Williams' opinion, because our health centers give a more comprehensive care. So they have transportation, enabling services, translation services. So our cost is a little bit higher. So that's why I was thinking, the FQHC market basket rate has been higher than the MEI. But something that's shifted in the last couple of years, I haven't looked at the data, but this is something just to look at. And for any FQHCs on the call, please make sure that you fill out your Medicare cost report accurately with all the information so the CMS can make the best decision with the best data available. But shown on here, the base rate for the Medicare PPS rate for health centers is 207.72. This is adjusted by the geographic adjustment factor. So depending where you are in the country, it will be adjusted based on where you are. Next slide. So this is one slide, but this is one slide I've been looking at every month for the last couple of months because things are changing very rapidly and it's very fluid. So one thing that has changed, the supervision definition has been permanently changed. So this is great for health centers because now they have the flexibility to have the supervision. It's not direct, but it can be general supervision. So this enables health centers, because a lot of health centers have sites that are like 3 hours apart. Whereas now they have this remote supervision. It gives them the flexibility to have that supervision for all these telehealth visits for different areas. So that is a great win. And so then now for non-behavioral health visits, the telehealth benefits have been extended until December 2027. So FQHCs can still continue to bill the G2025 for those non-behavioral health visits until the end of 2027. So this is great. It doesn't revise the definition for the, audio visual, but still being able to still provide these services is great. And then the last thing on the slide I want to talk about is the in-person visit for mental health or / behavioral health visits. That's been extended until January 2028. So during the public health emergency, they delayed having health centers having to have an in-person visit in order to deliver care via telehealth. They extended it out to January 2028. And with all things going on, with all the behavioral health, mental health challenges in the country, extending this out to January 28 gives health centers the flexibility to let the patients know that we don't have to see you in person now, but we will need to see you in person by January 2028 so that we can still provide these services for you via telehealth. Because in the surveys we've seen on our side, patients really enjoy telehealth visits where they can be in their homes. They don't have to worry about transportation and just get that care and get that one-on-one interactions with their provider. And I'll do a little sidebar. During the public health, during the COVID public health epidemic, we were talking to some different providers, and one provider shared the story that he did a first telehealth visit with the patient. It was a behavioral health visit. It was 10 o'clock in the morning. He logged in with his patient and he could see the settings where the patient is. And the patient was there for their telehealth visit at 10 o'clock in the morning and they had a glass of wine. And the provider was like, okay, it's great to see you, but let's talk about your need to have a glass of wine at 10 o'clock in the morning. That's something that you will never see in an in-person visit. So I just share that story to show the powerful impact that telehealth can have in giving the whole person care, to see the patient, where they are, where they live, and what they're actually dealing with from a day-to-day basis. Okay, next slide. So for care coordinated services, when it first launched out, they bundled all the services up to a G0511. So regardless of what kind of care coordination service you were given, it was rolled up into the G0511. And so now CMS said, we're going to not do that anymore, and you're going to actually code what you actually did. And I love this because having the G0511 simplified the billing a little bit, but you didn't get that the data on what you actually did for that patient. So for CMS to pull this out to say, code what you actually did will give so much more actionable data so you can treat the patients for what their concerns are. So I do really love this, taking away the G0511 and having you be able to code exactly what you did for the patients. I think that was just a win-win for everyone. I put a link in here for all the different care management because there's several care managements. And that's another thing I want to, apply CMS for, because they realize taking care of patients is complicated. So all these different care management codes, you have chronic care management, you have principal illness, all these different things. This is meeting the patients where they are and reimbursing healthcare providers for the services they're giving above and beyond the normal just in-person visit. Okay, next slide. Okay, so this is on remote evaluations. So another thing they've, took away from just billing one generic code and then having the detailed code to say exactly what you're doing. Remote image submitted by patient, remote image submitted by patient, a non-E&M evaluation and management, and then brief communication. So this way when you're billing for the information this way, you can see exactly how you're communicating with that patient so you can optimize your data and your care plans for your patients to see how are you communicating with the patient, what's the best way, and then you're getting reimbursed for that. So this is definitely another win, in my opinion. Next slide. So now we're going to talk about some of the things on behavioral health outside of the Medicare PPS rate. Next slide. So APCM, Advanced Primary Care Management Codes. So you see on here that we have 3 different codes depending on what the beneficiary needs to get services. So having one chronic care condition or fewer is a 556. Beneficiaries with 2 or plus chronic care conditions is a 557. And then beneficiaries that have a qualifying Medicare beneficiary with multiple disease, chronic conditions. And I should have pulled up the stat, but most Medicare populations right now has at least 2 or more chronic care conditions. So all the stuff we're talking about that we're billing outside the normal visit that they need, most Medicare patients are eligible for that because they do have more than one chronic care condition. And to highlight this is like integrated behavioral health with primary care has shown statistically that it's a better care plan for your patients, meaning when you're coming in for a primary care or, your diabetes or your hypertensions, if you, in that same visit, address behavioral health or mental health issues, it's a win-win for the patients. For number one, a lot of patients have transportation issues. Having this all taken care of in one visit is a win. And number 2, having that primary care physician that this patient has had a relationship with for years and addressing these behavioral health, mental health issues is definitely a comfort zone for them. So having to be able to build these add-on codes on this APCM for these behavioral health issues is definitely a win for the patients, a win for the mental and behavioral health foundation of our country. So having these things put in is great. It's great. Now, do you need to set up your systems in order to do this? Absolutely. But once you set it up and once you train your providers and your supporting staff on how to collect this data and bill for it, it's going to enrich your reimbursement and then make sure your patient is taken care of to the highest level. Next slide. So these are a couple of things: community health integration and principal illness for behavioral health. For one, CMS expanded the providers that can give these services. It extended to marriage family counselors, mental health counselors, and CHWs, which is huge because, as we all know, we have a workforce shortage in our country. So by CMS extending who can deliver these services just makes it improves access for everyone. So that is a win-win. So if you're at your organization, if you don't have some of these additional providers, you might want to look into recruitment for these different providers, because you can provide these services, just like with some of your other core providers for Medicare. And so looking at finalizing the psychiatric diagnosis and the HBI codes. So we are having some things and replacing social determinants of health with upstream drivers. But at the end of the day, what I like to focus on, the words might change, but the work is the same. We're taking care of the patients where they are. So we're just we're just going through and doing what we need to do in order to take care of the patients. Okay, next slide. So just a little bit of NAC. NAC responded to the behavioral health request for information, and a couple of things that we noted here. One, we noted that the annual wellness visit depression screenings should be outside of the bundle for the APCM bundle. And what I say for that is an ounce of prevention is worth a pound of cure. So having that outside of giving the cure and just reimbursing patients. And then also from a patient standpoint, if you put it on the preventive side, they don't have the deductible or copay. So that's a win-win for them. So this is just a little bit thing on our kind of policy side, and also eliminating cost sharing for APCM. So with cost sharing, there's services that you deliver in APCM that the patient might not see the provider. This is things they're doing behind the scenes, but we still have to charge that 20% co-insurance for that patient. And that could be a barrier of care for the patients. So we could remove that and say, this is something that's going to make the patient better in the long run. That'll be a win-win for everyone. So far as health centers, we do have our sliding fee discount, so we can slide that co-insurance, but that still could be a barrier of care if it's, $20 or $30 a month. So that's what our recommendation was, to eliminate the cost sharing for these services. And honestly, for any care coordination services, because it would definitely lessen the burden on the patients. Okay. And next slide. Thank you. And so here on the G code, G0136, the social determinants of health risk assessment. This is an assessment you can do to assess the patient's physical, what they're going through. And while FQHCs are doing this, we're not reimbursed for this separately, because with FQHCs for the Medicare PPS rate, we have G codes that trigger the payment, and the G0136 doesn't trigger for payment. Now, health centers are doing this because this is great data to collect to show what you're doing, how you're treating for the patient, and what you need to do downstream to take care of that patient. But unfortunately, it's not reimbursable for FQHC. So this is something that we want to advocate to get us reimbursed for. Next slide. And so then, so they have the Medicare Diabetes Prevention Program. So this is something I feel FQHCs should build a program that utilizes the MDPP program, along with how we have our medical diabetic services that we get our PPS rate for. So looking at the whole plan on how you treat your diabetics for better outcomes. So using this new Medicare Diabetes Prevention Program with what we're already doing in diabetes management and building it all together. Next slide. And so here are some of the resources we have. The NAC Medicare reimbursement tips. So we have this wonderful document that one of my colleague, Cassie Lindholm, made, where it's pretty much all things Medicare from an FQHC standpoint. And there's links and clicks from all the care coordination programs we have out there, the telehealth, which we do need to update the telehealth because that changed recently, just a couple of weeks ago. But this is a great resource. And as of course, the CMS webpage and also the CMS FQHC Center. If you're not at FQHC, I think you should have a champion at your health center that's looking at Medicare website regularly to see how things are changed so far as chronic care management, telehealth, and things like that. But definitely, if you're at FQHC, you should have someone at your organization that has this website benchmark, because it is updated regularly with current information on how you can definitely adapt your clinic to be compliant with all the different changes in Medicare CMS reimbursement. So you should definitely have, everyone should have a Medicare champion at their health center who's looking at different things in Medicare and who's a champion in educating everyone else on the changes in Medicare. And I don't know if you guys heard about the silver tsunami, but 10,000 people are being eligible for Medicare every day. So this population is just growing. It's not decreasing. So this is one, I'm an accountant. It's a revenue generator, but also it's a quality of care for your patients. So the more you can get reimbursed for, the more you can provide those high quality services that I know you give for your patients. And with that, I think I'm at the end of my slides.
Wonderful. Well, thank you. What a fantastic presentation, both of you. Thank you, Jake and Gervean, for sharing your insights. They were very practical, and I know everyone benefited a lot. And then we have a lot of questions coming in as well. But I wanted to highlight something that Jake presented in his talk. And I want to make sure all our members actually listen to that very important announcement. He said CMS acknowledges that lifestyle medicine frequently uses shared medical appointments and current billing through E&M visits with MTM and individualized care plans is allowable. Further guidance may be issued to better support this model. And currently billing group visits under existing guidance remains permissible. So make sure all of you understood this. And we will definitely share this with our members, because this is something that all of us needed, some clarity, and this is very valuable. So thank you, Jack, for working with us and for making this formal announcement today. So I have a question for you. Last year, ACLM members responded with great enthusiasm to the lifestyle medicine questions, which were in the PFS proposed RFI. And as you look ahead, 2026 and 2027, could you share how CMS is thinking about those responses and whether they're shaping any current or future policy direction?
Thank you so much, Dr. Patel. So just a couple of notes on that. I want to be clear that current practice is permissible for shared medical appointments, exactly as you described, and typically, and there was substantial E&M guidance that had been transitioned in about 21 to billing based on medical complexity or MDM, and so or medical decision making, as you stated. And so this is one mechanism, and I'm doing my best to say right now this is permissible.
Yes.
And we hope to be able to issue more clear guidance in the future, but lean to your organized medicine groups like the ACLM, the AAFPs has written on this, and there's historic guidance from HHS from many years ago. But just to say exactly as Dr. Patel described, this current practice is permissible. Now, with regard to the prevention wellness RFI, this was, I hope we all just acknowledge, and I think this is important to say, that we went through the longest government shutdown in our nation's history just this fall. And so please allow me some grace with regard to the fact that we did not summarize the entirety of the prevention RFI in last year's fee schedule. That was just due to staffing and bandwidth considerations. We are taking under deep consideration the categories of feedback that we received. So we heard from, just now, Gervean and NACHC comments specifically on the BHI elements, and that's really, really important. And double click that there's more that we're thinking about with regard to how we should be supporting behavioral health. With regards to categories of things that we had heard, and these are kind of categorized by our questions. So we specifically sought guidance on if there's anything further that we can do with regards to medically tailored meals. And this is a question about from the Food as Medicine folks that were in Q&A. And so we sought specific guidance on this. We also sought specific guidance on health coaching. There's been a question that's highlighting the current Category 3 T codes on health coaching that we understand are currently paid for with local determinations by our Medicare administrative contractors. We also, and part of the health coaching question was, what are the elements that we can use to address social isolation and loneliness, which is a priority of Dr. Oz's and something that we consider to be critically important to address for our nation's seniors. There were additional questions on digital mental health treatment. There were some intensive lifestyle change questions that we think lifestyle medicine docs are already implementing to such a degree. But these broad categories of feedback we're internalizing and working to do more. The best place to see this will be when CMS is able to speak publicly on the results of this RFI and in the rulemaking, and that will be, fingers crossed that it happens in June as is expected, but as part of the calendar year rulemaking for the physician fee schedule. Right now, I will note that if you are listening to this webinar, your ACLM leadership is advocating within CMS currently for us to take action as aligned to the evidence on this prevention RFI, and so more to come in the future.
Great, thank you. And so next question I have for Gervean. In states where collaborative care model is included on the Medicare fee schedule, can a FQHC clinician bill for collaborative care services provided to a Medicaid patient separately from the PPS rate they receive when the patient is seen?
So for Medicare, they can bill separately for those services, but every state is different. A lot of states follow Medicare, but it varies. So for Medicare, yes, you can, but you'll need to look at your state plan amendment to see exactly what is reimbursed for Medicaid.
Yeah, and is there any guidance from NAC about what each state is offering?
Well, right now what we're doing is, behind the scenes, we're looking at some of the financial challenges for health centers, because health centers, they don't make a lot of money. Our operating margin is like 1% on average across the country. So we're looking at things they can do to get more reimbursement. So we are looking at seeing state by state what you can bill outside of the Medicaid PPS rate, so that we can have a collective information on things that health centers can take advantage of.
Yeah, that would be very helpful. Thank you. So Jake, I have a question for you. The low access payment structures for managing chronic disease in traditional Medicare are top of mind for many of our members, and obviously you've heard a lot of people on LinkedIn as well. Given the reimbursement constraints of this model, what types of interventions do you see as clinically and financially viable, and what does a sustainable implementation model look like for access participants?
Thank you so much for this question. Part of my bio that I should have included at the top was I spent the last 4 years building alternate payment models with the CMS Innovation Center, and I think the access model is a fantastic example of innovation from the Innovation Center, and particularly this introduction of individualized outcomes-based payments. I think ACLM are leaders in this space of saying we implement lifestyle changes, and these lifestyle changes lead to sometimes diabetes remission or reductions in new maintenance or reduced need for medication for blood pressure control. And what you're seeing is sort of, for the first time, you're seeing the opportunity to participate in a payment model that specifically rewards this work. I think you're also seeing some concern, and if I'm tracking the public messaging, concern about sort of exactly how this is supposed to move forward with traditional brick and mortar lifestyle medicine. And I sit over at the Center for Medicare, and so wasn't directly related to the specific determination for this payment rate. But I think what this is meant to encourage is saying there's I know the team quite well, and so what they're calibrating is saying, based on their market research, they want to identify the expected resource needs for technology-enabled care. And as more and more of our clinical care delivery incorporates technology-first platforms, broadly speaking, agentic AI and artificial intelligence, I think there's an assumption that we're getting substantial efficiencies from this technology-enabled care delivery, and it'll be attractive for the organizations that are looking to scale technology-enabled care. Now, I'm a humble primary care doctor. I take care of patients in FQ in Maryland. I recognize the challenges, particularly for modernizing our technology infrastructure anywhere. And I want to say that while the access model is remarkable in how forward-looking it is, we do continue to make payment adequacy improvements across the fee schedule, in particular the physician fee schedule, to support typical Part B Medicare practices and FQHCs. And so we are continuing to speak with one voice. We want to support primary care and lifestyle medicine. This new technology-enabled variant, I think, is going to be teaching us a lot about how this can work and where we can support innovation in the market. And we're really excited to see the uptake from the access model.
Well, thank you. Gervean, I have a question for you. From Christina. She says, I'm a pharmacist certified as lifestyle medicine provider, providing lifestyle medicine service at a FQHC. I haven't been able to find the best way to bill. How would I go about finding that information?
So for pharmacists, they're not considered a core provider for the Medicare PPS rate for FQHCs, but for Medicaid programs, it's different. If you are FQHC, I would reach out to my primary care association. So they should have that detail on what you can bill for a pharmacist. And they are expanding these things on Medicaid programs across the country, but it's just not a core provider for Medicare just as of yet. So I will look at my primary care association.
Wonderful. Thank you. I have a question for Jake. As CMS is supporting upskilling to grow the rural workforce, will CMS reimburse the certified addiction specialists and certified community health workers for mental health care and other care?
Being described as a rural issue. I think so we know addiction cuts across like urban and rural lines. We also know the needs for mental health care improvements are great. I want to touch a couple of pieces in terms of where we went last year in rulemaking and sort of to double click on some of the points Gervean made. First, in that constellation of primary care services with advanced primary care management, as Gervean stated, we are adding on behavioral health integration. I think it's a really important step to supporting behavioral health care in this country. Second, we acknowledge that there's so much more to do. And so if we want to continue to support patients' mental health, of course, there is the digital mental health track in the access model. That's one step. Of course, the Innovation Center continues to evaluate and find the previous demonstrations in behavioral health for the value in treatment demo that was congressionally mandated, and in addition, the innovations in behavioral health demo that's ongoing. These are really important bright spots that are teaching us a lot. In terms of who's delivering the care, there's been substantial work to expand the primary care workforce, and I'm trying to respond to a couple of questions altogether, incorporating new members of that interprofessional team. I think I'm in contact on a seemingly a weekly or daily basis with organizations who are informing me that we have more to do with regard to like who can deliver these important services. We have a posture at CMS of wanting everyone to practice at the top of their license, to incorporate more and more qualified individuals into care delivery. If for some reason there's a sticky issue, I've already thrown my email into the Q&A specifically asking for folks to reach out to talk more. But our posture really is that historic challenges with these billing requirements are sort of our duty to look into really closely. So I think, and so please email me, reach out, happy to speak more, and really grateful for the question and for your dedication to caring for rural patients. As a kid who grew up in a town about 30 minutes from the nearest stoplight, that hits pretty close to home.
Yeah, thank you. So this could be either of you. With FQHC, it is difficult to bill for services like nutrition therapy or health education. Will these services be made more accessible?
I would say for Medicare, diabetic self-management training is something that if this can fall underneath. Now, if the patient is not diabetic, there are some challenges to doing that. But if they are diabetic, that is something that you can definitely bill Medicare PPS rate for.
Mhm. Okay. The next question is, as board certified ACLM and licensed physical therapist, can we bill LSM education individual and group for our physical therapy clients? Would we use LSM codes versus regular PT codes?
So that is something that the whole group visits and things like that for Medicare, I'm not familiar with. So I could do some research offline and maybe follow up after the webinar to respond to that. Jake, do you have anything to add to that?
Just that if you ask us enough questions, even coding payment exercise, Gervean and I, you're going to catch a gap in our knowledge, and I'm in the same place. And so I think would love to talk more and try to understand the specifics of the issue. And we acknowledge, I think, Gervean, my interpretation of this question is that there's more clarity that's necessary for the group visits, and particularly for happy to look into this more on the physical therapy side. So you've not that you stumped the experts, because we're not experts, but we're grateful for the question.
Right. No, this is fantastic. I think this conversation has been so valuable for our members, and especially both of you taking the time and really being with us. I think this has been, we deeply appreciate your time. And I want to now bring in Kathleen for some last slide and some instructions before we close out. Kathleen, take it over.
Thank you so much, Dr. Patel and Dr. Quinton and Gervean. It's been lovely to have you all here. We appreciate your time and expertise. We know that this information is super helpful for our members to be aware of. Before we log off today, we do want to remind you that we also had a webinar series in the month of January where we talked about the new CMMI models. And we wanted to point you to the QR code where you can access those recordings and the slide decks from those. So if you are looking, we really hope lifestyle medicine clinicians will engage in some of these models. We know that there's a huge opportunity here, and we want to see lifestyle medicine clinicians be really successful with both Access and MAHA Elevate. And mark your calendars if you haven't already. Registration will soon open for ACLM's annual Lifestyle Medicine Conference. Next year we will be, or this year we'll Orlando, Florida again, from November 8th through 11th, and it's going to be a fantastic lineup. So if you haven't yet, put that on your calendar and be prepared soon for when we launch registration. And then finally, if you enjoyed today's webinar, we do want to invite you to sign up for and look at some of our upcoming events. We host complimentary webinars. We also have a vodcast and a podcast where we're talking from really about lifestyle medicine mentorship. And all of these are freely available at our website. You can access them via the QR code here today. And again, I want to thank everyone for your time and engagement in today's webinar, and really tremendous thanks again to Jake and Gervean for being here with us today. We hope everyone has a wonderful rest of your day and week, and we look forward to seeing you hopefully soon. Thanks, everyone.
Thank you.
Thanks.
Bye, everybody.